Welcome to today's webinar under the title Spotlight on Sickle Cell, Understanding the Disease, brought to you by the UWI Mona Library Health and Wellness Committee, LHEWco, in collaboration with the Caribbean Institute for Health Research, CAIHR. I am really delighted to be partnering with CAIHR on this webinar to raise the awareness on this rare and potentially life-threatening condition. I am Tamar Stretch Heron, Chair of LHEWco and your moderator for this webinar. I will be assisted by other members of the LHEWco team, Mrs. Latoya Johnson-Phillips, who will lead us in prayer, and the rest of the team who will be monitoring the chat and managing this meeting. Please allow me to introduce them. Mrs. Ruth Rooms Yafar, Miss Nicole Johnston, Mr. Miguel McCoy, and Mr. Paul McFarlane. Throughout the next hour and a half, we're going to be meeting several incredible people from different facets of the sickle cell community. We have got Dr. Lesley King, Head of the Clinical Services at CAIHR, Mrs. Catherine Dawson Shaw, Manager, Individual Benefits and Research at the National Health Fund, NHF, and the spotlight is on Mr. Sean Taylor, living with the sickle cell disease. Before we begin, I would like to review a few housekeeping issues. If you may, today's webinar is being recorded and it will be shared via the library's YouTube channel. We will be hearing from all our presenters first. Then we'll have our questions comment at the end of that section. And it will be asked in the order received. We will do our best to answer as many questions as we possibly can, given the limited time. I have some questions of my own, but really, what we want to do is to be hearing from you. Right? So please allow me to now invite our prayer warrior to lead us in prayer, Mrs. Latoya Johnson-Phillips, to lead the proceedings. Then we will be hearing from our Deputy Campus Librarian, Mr. Dunstan Newman, who will bring his greeting and introduction of the speakers. Okay, okay, Stretch, enough rambling from me. Mrs. Johnson-Phillips,
and all to
over to you.
Good morning again. Are you hearing me?
Yes, we are.
Okay. Father, in the name of Jesus, we just want to thank you, mighty God, for the opportunity to come together in this fashion, mighty God. We might not have been able to come together in a face-to-face fashion, but we're glad for the technology, mighty God, that we can come on the Zoom platform. We pray, oh God, that you will just open our understanding, mighty God, that we will be able to understand whatever will be shared, mighty God, about the sickle cell disease, mighty God, and how to deal with persons that are affected by the disease, mighty God. I pray, oh God, that you will just open our heart, hearts, mighty God, and just show us ways that we can be of help, mighty God, to the individuals that are affected, mighty God, or to the team that is working, mighty God, on the ground to help out the persons that are affected. I pray, oh God, that you will just, mighty God, be with the workers, be with the presenters, mighty God, as they come on the platform, mighty God, to share what they know, mighty God, and let them be able to answer each and every question and answer them in a way that we will be able to understand, mighty God. I pray, mighty God, that you will just allow the proceedings to go forward without any glitch, mighty God, without any internet or any other challenges, mighty God. As we surrender all to you, just let your will be done. In your mighty name, Jesus. Amen.
Okay, thank you, Mrs. Johnson Phillips. Mr. Newman?
I'm coming. Good morning, everybody. And I'll be brief. Just a word of correction. I'm the acting deputy campus librarian, and I don't think it was deliberate by Mr. Heron. And as I thank him for that, I'm speaking into being, but I'm not quite sure about that just yet. So first of all, I'm bringing greetings on behalf of the acting campus librarian, who is acting for Dr. Paulette Carr, that's Mrs. Jessica Lewis Marshall. And I'm going to read, I just scribbled something down here. So I bring greetings on her behalf on the library administration in total in this effort of Mr. Heron's and his team's initiative in promoting health and wellness of the staff and the magnitude that it has taken off. It came about during COVID and it has continued, and we are proud, especially I'm seeing the outcome of it. The numbers may be small, but they are persistent in their initiative and activity. And this particular event that he's hosting this morning is very important. And therefore, I bring the greetings to see to endorse the support that the library has and will continue where I'm sitting from, in the sense that it's not only for physical, but also for psychological and physical well-being of all staff members, which is very important. So he does not, or this particular group, he and his team does not just focus on the physical aspect of things, but also the psychological and emotional aspect of things. In the interest of time, I will not labor, but I will introduce now two persons that are here to speak today. And I'm seeing just a moment, please. There is Dr. Lesley King and Mrs. Catherine Dawson Shaw. And I have Mrs. Shaw's bio in front of me. She's an experienced, dedicated, detail-oriented health professional driven by standards of excellence and a desire to provide assistance to persons where possible. She's a graduate from UW and also from UTech. She's a pharmacist, both working in the private and public sector. And she also has she comes with other accolades, such as she has worked in quality management system, training and development, and pharmacy service. And she has some unique and outstanding skills, such as leadership, interpersonal skills, oral and written. And she also executes in planning events and also training, and none other than she's also a critical thinker. So we are coming to see a very well-rounded person to give her talk this morning in that respect. The other person that we have is Dr. King. She's a pediatrician and she's also held at the Clinical Services and Tropical Marine Institute, TMRI. She's been working in the sickle cell unit at CAIHR and since 2000. And her early research focused on newborn screening and renal disease in children with SCR. And she's now focusing on digital transformation, the clinical services at CAIHR. So therefore, both persons come well equipped, especially with what the theme of this presentation here today. And I trust that the information garnished and being held by the host will be something looking forward to. Sharon, it's all over to you.
Thank you, Mr. Newman. And yes, we are speaking things into being. That's what we do, promote a healthy lifestyle and positive thinking. So everything begins with a thought. Okay, thank you again once more. Dr. King, you have been made co-host, so you may begin. You are invited to share your presentation.
Great. Thanks, Mr. Heron. Thanks, Mr. Dunstan. All right, let me just share my screen. Okay. Is everybody seeing my screen?
Yes, we are.
Oh, hold on. I've done something bad. I've taken it off of slide view, haven't I? Okay. All right, great. Okay, so before I start, let me just say thank you to Mr. Heron and the team at LHEWco for inviting me to speak on sickle cell disease and just, share some information on sickle cell disease. It is actually Sickle Cell Disease Awareness Month. And so this is a very timely presentation, and it's a very timely initiative, okay? And I can't underscore the importance of just improving just public education, public awareness in improving the lives of persons who have sickle cell disease. The more that we know is the more that we are able to help persons who live with disease. All right. Okay, so what exactly is sickle cell disease? Well, I've underlined here chronic and hereditary. So it's chronic, means it lasts a long time, and it's a hereditary disease. Persons are born with it of their red blood cells. It is a multi-system, potentially debilitating disease, which is characterized by severe, unpredictable pain crises, chronic organ damage, and reduced life expectancy. What exactly is the problem? Well, persons with sickle cell disease produce an abnormal hemoglobin called sickle hemoglobin. Now, hemoglobin is that protein molecule in our red cells that carry oxygen. And persons who have normal hemoglobin have what we call hemoglobin A. Now, our normal red cells are very round, they're very soft, and they're very flexible cells. And these are the red cells that contain hemoglobin A. However, when the red cells have sickle hemoglobin or hemoglobin S, it changes the characteristics of the red cell. So they now become what we call sickle shaped, and that's how they get their name. So they're like a banana. They have a very short lifespan. The normal red cell lives about 120 days, which is like 4 months in our circulation. The sickle red cell only lives for about 10 to 20 days, so that's less than 3 weeks. And as I mentioned before, the normal red cell is a very soft, a very flexible cell. On the other hand, the sickle red cell is a very rigid, it's a very sticky cell, and these cells tend to stick together, clump, and because of that, it affects the circulation or the flow of blood to the various tissues. Now, sickle cell disease is actually an umbrella term. So there are many different types and many different forms of the disease. We most commonly hear about HBSS disease, and that's the type that persons tend to refer to as full-blown sickle cell disease. But there are other different forms of sickle cell disease when you have sickle hemoglobin combining with another abnormal hemoglobin, and they are all sickle cell disease. And these different forms tend to be very variable in their severity. So with regards to severe disease, HBSS, which is the most common type of sickle cell disease that we are aware of, is a severe form. But there's also sickle beta thalassemia 0, which is another severe form of disease. When we speak to mild disease, we usually tend to refer to SC, sickle cell disease, as well as sickle beta plus thalassemia. And apart from these 4 forms that I have listed here, There are many other different forms, and the frequency or how often you see these forms will vary depending on what part of the world that you live in. Now, how do persons actually get sickle cell disease? Well, as I said, it's hereditary. So they inherit abnormal hemoglobin genes from both parents. So it's not mommy alone or daddy alone. They have inherited abnormal genes from both mommy and daddy. 10% of persons in Jamaica actually have the sickle cell trait. Now, the sickle cell trait is when you have normal hemoglobin A along with sickle hemoglobin. Another 5% of persons have other abnormal hemoglobin traits, such as the C trait and the thalassemia trait, that can lead to a child with sickle cell disease. Now, importantly, persons with traits do not have disease. They simply carry these abnormal genes and they're able to pass them on to their children, and traits do not develop into disease. So you can't have a trait now and then 10 years later you have disease. You do not, it does not change. All right. If you are a trait, you simply have a carrier state. Now let us look on some of the common inheritance patterns. So if you have one parent who has normal genes, so remember we each have two sets of genes, one we get from our mommy and one we get from our daddy. So if you have normal blood, red blood cells, so you have normal hemoglobin, you have two hemoglobin A genes. If you have the sickle cell trait, you have one hemoglobin A and you have sickle hemoglobin also. Now this partnership, as you can see, you get one gene from mommy and one gene from daddy. This partnership will not produce any child who has sickle cell disease, but does have a 50% chance, a 2 out of 4 possibility of having a child with the sickle cell trait. On the other hand, if both parents have the sickle cell trait, so both are AS, what you can see for this partnership is that there is a 1 in 4, so, or a 25% chance with each pregnancy of having a child with disease. For other types of sickle cell disease, if you have one parent who has a sickle trait and the other parent who has the C trait, this partnership, again, there's a 1 in 4 chance of having a child with sickle cell disease, but this time the SC sickle cell disease. And if you have a parent with sickle cell trait and the other with the beta thalassemia trait, this partnership, again, a 25% chance in each pregnancy of having a child with sickle cell disease. But in this situation or in this relationship, it would be the sickle beta thalassemia form of sickle cell disease. Now, sickle cell disease is not a new disease. We believe that the gene mutation likely originated in Africa hundreds of years ago. And unfortunately, this gene mutation has persisted in Africa, especially in areas in West Africa, equatorial Africa, where there is a lot of malaria. And the reason for this is that persons with the sickle cell trait have a survival advantage with malaria. So they get malaria less frequently, less severely, and are more likely to survive. And as such, the sickle cell gene has persisted. Now, because of the slave trade and then voluntary immigration, the sickle cell gene has spread from Africa throughout the world, and sickle cell is now considered a global disease. It occurs in all races, although it is more prevalent in persons of African ancestry. It's estimated that about 300,000 babies are born annually worldwide. 85% of them will be born in Africa. And important, the Caribbean has the second highest incidence of babies born each year with sickle cell disease. And in Jamaica, 1 in every 150 babies born has sickle cell disease. So every year, we have about 200 babies born with a form of sickle cell disease in Jamaica. Now let's just go through the natural disease course as well as some of the consequences and interventions that have had a significant impact. So if we look on the first 5 years of sickle cell disease, there's actually an asymptomatic period after birth. Your first symptoms won't appear until about the age of 4 to 6 months, with the most common presenting symptom being that of dactylitis. And dactylitis is basically where you get a painful swelling of your small bones, so the bones in your hands and your feet. Other common complications that we see in the first 5 years are starting to develop are the development of chronic anemia. So anemia, we know, is a low blood count or what we call weak blood, okay? There's jaundice, which is yellowing of the eyes, and very importantly, 2 complications, acute splenic sequestration and infection. And these 2 complications are of extreme significance because it's because of these 2 complications why the first 3 years of life with sickle cell disease is actually very high risk for morbidity and mortality. And when you look at somewhere like in Africa where the disease burden is greatest, 50 to 85% of those babies who are born in Africa will not reach their 5th birthday. They will die before their 5th birthday, okay? And that is just tells you how significant this early childhood period is. So what can we do? Well, one of the things that we try to stress is the importance of newborn screening. So diagnosing disease very early, and we can diagnose disease from shortly after birth. We want to enroll our babies into a program of care. We want to start disease education, genetics, complications of the disease with their parents, their caregivers. And we want to also start implementing what we consider very cheap interventions that have a significant impact on morbidity and mortality. Penicillin antibiotic, very cheap, you can't get much cheaper than that, has helped. The use of penicillin in the early childhood years has helped to decrease mortality, so death from infection. Splenic palpation, and I'll show you that in a little while, as well as vaccinations, very simple. And in this first 5 years, we can actually think about disease modification, which I will also speak about later. Now, acute splenic sequestration is a very common complication in the first 3 years of life. And basically, we all have a spleen. It's an organ like how you have a liver, kidney, lungs, heart. We all have a spleen, and it lives in the left side of our tummies, underneath our rib. Now, the spleen acts like a sieve. So it basically helps to clean up our blood. So as our blood flows through the spleen, it helps to remove old red cells, old white cells. It helps to remove germs, bacteria. Now, in children with sickle cell disease, and we don't know exactly why it happens, okay? But as the blood sometimes is passing through the spleen, it sickles, so it means it takes on that banana shape, and the red cells get blocked inside of the spleen enlarges, it gets swollen, okay? And the result of this is that there's very few red cells circulating around the body. And so your blood gets very weak. It is an emergency and it is potentially fatal. The simple intervention here, and we're showing you here in this picture, of teaching parents how to check their children's tummies, okay, to detect an enlarged spleen with the simple instruction that if you feel your baby's spleen is enlarged, take that child to the nearest hospital immediately, has reduced the death rate by about 95% from this complication. Simple, cheap, but very effective. If we look on the 10-year survival between 2 cohorts of patients at the sickle cell unit, the first is the Jamaica sickle cell cohort study. So this is a group of babies who were screened or diagnosed from birth between 1973 to 1981. Now, this group of babies is well known worldwide in the sickle cell disease literature, okay, and they have been followed from birth. Essentially, a lot of the lessons on the natural history of sickle cell disease has been, they have been informed from this group of patients. And then we have the Jamaica Sickle Cell Unit birth cohort, which is another birth cohort when we started newborn screening back again in 1995. Now, the first group of babies, or the Jamaica Sickle Cell cohort study, we split them up into like 3 groups. This first group, very little interventions, because we didn't know anything about the disease at the time. The second and third cohorts, or groups of this study, interventions were started as, you know, the lessons were learned. And with the current cohort study, interventions were started from day 1. We screen, we start interventions. And if you look here at the age of 4, okay, 18% of this first batch of patients would die. In the second and third cohorts, proportion of deaths from 7 to 8%. In the current cohort, less than 1.5% are dying by their age of 4 years. And this is simply because of early diagnosis, care, and simple interventions. These makes a huge difference. If we go on from the early childhood years into adolescence, we see other complications now starting to take, you know, light. Recurrent bone pain. So these are just basically unpredictable pain crises that occur at any time. And, you know, the pain can vary from very severe, requiring opioids, or it could even be very mild pain, but unpredictable, happened at any time. We also have acute chest syndrome, which is like a pneumonia, but a little bit more than a pneumonia. Children with sickle cell disease are at risk of getting a stroke. So, you know, your granny with hypertension can get a stroke. Well, children with sickle cell disease can also get strokes. Eye problems, we have problems with delayed growth and puberty. They can have damage to their hip, which can cause pain and impact their walking, as well as they can also start to get leg ulcers, which are, you know, if can you just imagine a little sore on your leg that becomes a big ulcer, which months and years will not heal. This is a problem for our patients. So the consequences of this, ongoing morbidity and mortality. There's missed time from school and work for parents and caregivers. It affects their school performance. And then we start to see, especially as we move into our teenage years, psychosocial problems. So problems with self-esteem, image problems, because they may look a little different, especially if they are pre-pubertal, when all of their friends are, you know, are now into puberty, and they start to indulge in some of the risky behaviors, so smoking, you know, early sexual, early introduction into sex. And so we have to be mindful of these things. What can we do? Well, again, the importance of routine health care. We need to start encouraging patients to build what I call their support tribe. Your friends, your family. This is a situation where we all need a village, okay? You need to get your teachers on board, your peers on board. We can also start thinking about disease modification. Now, there is a drug, hydroxyurea, which has been used in sickle cell disease to modify how the disease works for about the past 30 years. We use it in Jamaica. Unfortunately, it's not used as much as we would like, but it is available. And for those persons who are on hydroxyurea, it can make a significant impact on their quality of life. There's also the possibility of disease cure, but I sometimes don't like to speak about disease cure because then everybody thinks, why don't we just cure everybody? Well, cure is not very easy, and cure is actually very expensive. The first, there's bone marrow transplantation and gene therapy, which is actually more experimental and in trials at this stage. The actual first patient who was transplanted for sickle cell disease was a child way back in 1984, and she wasn't actually transplanted for disease. She was transplanted because she had leukemia. And in transplanting her for the leukemia, they realized that they actually cured her sickle cell disease also. And as a result of that, it became a curative option. But as I said, it's not cheap. It's, it has its own challenges. And to be frank, where the burden of disease is greatest, these kind of curative therapies are unlikely to have any significant impact now. And so here is where we need to consider and focus our healthcare, simple interventions, and disease modification. With regards to our adults, again, the common complications, as well as we start to see things like kidney disease and heart and lung disease emerging. We also have, the challenges with pregnancy and family planning. Patients with sickle cell disease can have children, okay? Our women, however, pregnancy is a very high risk period for them. And so what we try to do is encourage our patients to have planned pregnancies. And, that helps us for them to help to get them prepared in a healthy state or as healthy as possible going into their pregnancy. Consequences, again, ongoing morbidity, mortality, missed school and work time, challenges with higher education, okay? And because of this, it means then that what is available to them is low-skill jobs. And with any job, especially the low-skill job, you then have difficulty maintaining these jobs. So you have the psychosocial problems which are ongoing, relationship challenges, depression. And again, our intervention remains the same, but we also have to think about psychological input. As I said, I can't underscore the importance of getting your support tribe, all right? And helping to spread, don't hide the disease, but spread the disease, because by helping others to understand, you allow them to help you. Now, sickle cell disease care in Jamaica has been going on for quite a while, over 60 odd years, and we have had some significant achievements, okay? And here's just a few. So one of the things just with early childhood, newborn screening and early childhood care is that our under 5 mortality experience is no worse than that of the general population. Remember what I said about Africa. 50 to 85% of babies born in Africa with sickle cell disease will die before the age of 5 years. The median survival age for sickle cell disease in Jamaica, or HBSS disease, is 42.3 years. And this is comparable with, first world countries. Our oldest patient actually has SC, and that patient, he is 96 years. Our oldest patient with SS is 82 years, and our oldest patient with sickle beta not thalassemia is 89 years. So you can see that people can live with sickle cell disease for a very long time. Sickle cell disease was introduced into the National Strategic Plan for Chronic Disease in 2012, which means that there is policy now which guides sickle cell disease care in Jamaica. And this is so very important. And there's actually a sickle cell technical working group who is responsible, whose mandate it is to drive, the care of sickle cell disease in Jamaica. We incorporated island-wide newborn screening in about 2019, so that all babies born in Jamaica in either a private or a public hospital are now screened at birth for sickle cell disease and enrolled into a program of care. With regards to the NHF, and Mrs. Dawson Shaw will probably speak to this later on, sickle cell disease was included on the National Health Fund, which allows our patients to get drug subsidies, and this is from about 2015, as well as the sickle cell unit clients who are not really public, but they're not really private either. They were included in the drug serve so that our patients can access drugs under the drug serve since about 2021. Now, just as we wrap up, I just want to share some of the common myths about sickle cell disease and the real truth behind them. So sickle cell is only in Black people, and I've spoken to that. It occurs in all races, but it's more common in people of African and Asian descent. Women with sickle cell disease are infertile, they're mules, as we say in Jamaica. Definitely not. Our women with sickle cell disease are fertile, they can have babies, but there is increased risk of illness and death for both mother and infant, which is the reason why we try to encourage planned pregnancies. The leg ulcer, or the sore that you see that patients with sickle cell disease get on their ankles and yellow eyes, the jaundice is catching. You can't catch anything from sickle cell disease. It is an inherited, it's a problem with their genes. Everyone with sickle cell disease will die early, often by the age of 30. And we're shown on average, people live into their 40s and 50s, and we even have persons living into their 90s. Sickle cell disease patients cannot hold full-time jobs. Very false. Persons with sickle cell disease can hold full-time jobs in different industries, and they can add value to their organization and make meaningful contributions to society. If both persons have the sickle cell trait, and this one hasn't come up, they can have, if they have 4 children, one will have sickle cell disease and the other 3 will be fine. The truth is that with each pregnancy, the risk is the same. So there's a 25% chance with each pregnancy of having a child with sickle cell disease. You can identify a person with sickle cell disease by how they look. Well, we know that's not true. Okay, and you can look on our patient here with us today, Mr. Sean Taylor, and you certainly can look on him and know that he has sickle cell disease. In sickle cell disease, and this is a very common one, the white blood cells eat the red blood cells. No cell is being eaten by another cells. The red cells break down very quickly because they get damaged because of the sickling, but there's no red cell or white cell eating each other. And beetroot and iron supplements will decrease anemia in sickle cell disease. Well, anemia in sickle cell disease is not due to iron deficiency. And actually, if you give iron tonics or iron supplements, it can actually be bad for persons who have sickle cell disease. In summary, sickle cell disease is a chronic hereditary disorder of red cells. It can affect persons throughout their lifespan. Improved care and treatments have significantly impacted morbidity and mortality, and persons with disease can be productive members of our society, and education is a key factor in decreasing the burden of disease. It's important that we all know our status, especially if we are thinking of having families. And just acknowledge Prof. Sargent for some of the pictures used in this presentation. Thanks very much. And I probably went a little over time, but sorry about that.
No problem. It's a wealth of information and knowledge, and well received here today. And I'm glad that we have Mr. Taylor, a living testimony for what you have just presented. So thank you very much, Dr. King, for sharing with that. And let me just remind persons to and invite persons to go ahead and place their questions and comment in the chat, because we have a team that is monitoring the chat and will answer those questions. We place those questions to the presenters in the order received when that time comes. Now, Mr. Taylor, after Dr. King's presentation, I am now beginning to have a bit of empathy, so to speak, towards persons living with the sickle cell disease, because as Dr. King spoke about the swelling of the bone and the stickiness of the blood cells, I can only imagine how painful such can be. And you are a technician which deals with lots of critical thinking and moving. Can you guide us through your daily activity? Can you share your story with us, please?
Sure. Good morning. You hear me, Prof? You hear me clear? Hello?
Yes, go ahead, Mr. Taylor.
Okay, hi. Morning, everybody. So, yes, I guess I'm a living testimony. I've been through a lot. Sickle cell is challenging. Life has been challenging. Just to start, my name is Sean Taylor. I am a 51-year-old medical technologist. I work at the University University Pathology Department, Hematology, Blood Bank. Big up the crew. I am
Sorry, Mr. Taylor, sorry. Your volume is a bit low, right? So what I have done, I have turned up my own volume. So I'm just making this announcement to others. I've turned up my own volume on my speaker on the laptop, and that has helped. So I'm just advising persons, if you're not hearing clearly, try turning your volume up while Mr. Taylor will project for us. Go ahead, Mr. Taylor. Thank you. Sorry about that.
Yes, okay. Yeah, all right. Yeah, the connection kind of got it. Okay, so I was saying I'm a 51-year-old medical technologist. I'm married, 2 kids. I Andrew, like LHEWco, because of I'm currently employed university, the pathology department, hematology blood bank. I have been having I've been living the life. It's been very challenging, to say the least. Growing up, I was a sickly child. I was always sick, always ill, missing school a lot. I remember vividly being admitted to Bustamante for more than a week. I just remember bawling and in pain, just crying and bawling. Um, it was, I think it was the last day. I think the day I stopped crying was the day my mother came for me. And I guess that was the day I started. So it was, and well, life started for me kind of rough from primary school straight up to high school. High school, you know, you're trying to fit in, you're trying to be normal, you're trying to socialize, but then, you know, you have this chronic disease that, for the most part, is kind of hindering your progress. You make friends, but of course, you know, you don't really share that part of your life with people. Um, for the most part, what Dr. King said is true. You kind of hide it, but I, in particular, kind of hid my disease. It wasn't until recently, very recently, that I started to basically tell people or let people aware of my condition and what I've been through in my life. Um, I have been hospitalized 4 times. When I say hospitalized, I mean major hospitalization. I mean more than a week. Of course, you know, I've had days and stuff. I have to go to A&E and other treatment facilities, maybe like overnight, overnight stay or so. But I've had 4 major hospitalizations. I can remember. Oh, and just to let you know, I have S-beta. That's one of the forms of sickle cell that Dr. King had mentioned. They claim, well, it's supposed to be a milder form. SS is the one everybody knows. SS is the real. But trust me, when you're in agony, when you're having a 10 plus crisis, and so for those who know about pain, normally you'll go to the doctor and pain, they'll ask on a scale of 1 to 10. How bad is the pain? 10 being the most pain you can feel. So 10 plus crisis is agony. I was discussing with my cousin, Tamara. She and I were discussing the time. To her, she says it feels like you're being beaten by a bat continuously, repeatedly. But for me, I personally think it feels like, I don't know if anybody has ever had, they has ever bumped their knee into a table or into a jaw. That initial pain as you get when you bump your knee into that jaw, you magnify that 10 times, that's what it feels like. Excruciating pain. Other sickle cell patients will tell you, I know they will agree, when you're in that pain, you kind of try to find the best position you can find to kind of be comfortable. Right? So you be in pain and you turn this way, you turn that way, pain is still there. So in a little position, in a little relief you can get, it might be lying on your back, lying on your side, you kind of take it. You know, once you move, I mean, the pain is still there, but once you move, it kind of comes back to it. So the pain is really crazy. It's terrible. I would not wish to stay in my worst enemy. Trust me. Not pretty. But anyway, so I've had 4 major hospitalizations because of 10 plus sickle cell disease. I've had acute chest syndrome, and that's affecting my spoken about. Of course, pains in my legs, my arms, my back. Back pain is what I currently have more of now at the next old age. But yeah, I guess older you get, because what sickle cell does, it kind of wears your body down. It takes a toll on you physically. Your legs, your arms, you actually feel them getting weaker sometimes. Yeah, it takes a toll on you. So school life for me was more of trying to be normal, trying to stay under the radar. Of course, I love the things that socialization was an issue. You're not really the going out type, you're not really the sociable type. You're kind of, well, I know for me, I kept to myself. I wasn't really outgoing or very talkative, I was very quiet, like introvert, kept to myself. I wasn't really someone that would be out there, run up and down, and I was just like kind of chilling by myself. So high school was kind of challenging. You meet good friends, I have good friends along the way. But even when I met the good friends and I've had some decent people in my life, the stigma of sickle cell is such that you don't really tell people. I remember growing up, and someone said to me, because in growing up, my mother told me, yeah, I have sickle cell. That's why I was sickly. I don't know what sickle cell was. I just knew that at times I'm in pain and I'm sick. I don't know what method of screening that is then. Or she could tell me that I had sickle cell. She couldn't tell me what type, obviously. I think person she would know. But it wasn't really something I went around telling people then. I remember vividly in high school, missed a lot of school. I missed my 6C biology exam. When my friends in my class came, they were like, Sean, how come you don't come to the exam? I was like, oh, well, forget it. I woke up in the morning and I felt terrible.
Sorry, Mr. Taylor. Sorry. I know you are sharing your story here, and I know persons are trying to hear you clearly. Is it possible for you to? Sorry. So I was saying, sorry to interject, right? But we're not hearing you clearly. But what I have been hearing is pain, right? And I'm quite sure we would love to hear your story. And so clearly, is it possible for you to move closer to your microphone so that the volume could be amplified?
Mr. Heron,
yes,
let me put him, he's at the unit, so let me put him on where I am.
Okay, so
okay.
Would you like me to proceed while you do that and then come back to him? Or
it'll be like 10 seconds.
No problem, I'll wait.
All right.
Okay, thank you.
Yeah, the connection is, the volume keeps drifting in.
Yes, so what I have been hearing thus far is, go ahead, try again, is that Mr. Taylor has sickle cell disease, and his life has not been, quote unquote, the normal kind of life, because he struggles daily with severe pain. I think Dr. King referred to that as a crisis, right? So we would definitely like to hear from well, as they would say, from the horse's mouth, what it is like living with this kind of condition, right? And I'm also going to use this moment to remind persons to place their questions and comment in the chat, where we have our team monitoring that, and we'll try our best to get through to all the questions today. If not, we'd just like to remind persons again that this is being recorded and it will be shared via the library's YouTube channel. All right. So, Mr. Taylor, we're coming back to you.
Yeah, hi. Okay, sorry. All right, so I don't know how much of that you heard, but okay. What I was saying, growing up, you have this, you're aware that, I mean, you're not normal. I don't know if normal is the word to use. You're growing up and you have challenges in terms of your health. So I think I started telling you about the whole social issue where after a while you're excluded from certain events, certain events. So you'd be going out, you'd have friends, you know, you'd want to go to your friends, but then after a while you keep telling them, boy, you can't come out. You make plans with them and you don't turn up. After a while, it got to a situation where you just hear that, oh, you know, we went here, we went there, and you're like, nobody told me, you guys know where we're going. And that was kind of the thing. I mean, after a while, you got excluded from stuff because you were always sick. One friend told me point blank, said, boy, you know, yeah, we like I tell you, but you're always sick. You know, we figure you couldn't come, or, you know, you always have an excuse. So after a while, I just realized that it is what it is. You just have to just have to face up to the fact that you're going to be excluded from stuff. I try to live as normal as life as possible. I mean, with sickle cell, it's not really always possible. You always feel like you have to be doing more, trying harder than everybody else. I know, especially in terms of like work, there's this misconception that patients with sickle cell are lazy. It's not that we're lazy, we're just tired or we're just sick most of the time. I remember in high school, my history teacher, I mean, there's always that one teacher in high school that does take a set on you. That was me and this history teacher. So most of my high school classes, I'm at the back of the class in a little corner trying to be inconspicuous, not being seen. And this lady would always come to class and she'd pick me out and she'd like, Mr. Taylor, I see you in the class, you're not paying attention. I was paying attention. I actually loved history. It was one of my better subjects. I loved it, but some of the time I just wasn't up to it. So I'm in the class in the corner trying to chill. This lady would tap me on, Mr. Taylor, you're doing my work, are you around here? Of course, I tell my mother, and my mother's a teacher as well. She teaches primary school. So she's like, why you don't tell the lady you're sick? I'm like, okay, yeah. Mothers know best, right? I'm like, no, not all the while. Love your mommy, but not all the while. So I said it to the teacher, and she's like, okay, all right, fine. For the next 2 classes, that was good. The 3rd class, she's like, oh, Mr. Taylor, you in my class again, you're not paying attention. And trust me, it got worse from then on, because I guess to her, I was just using the illness as an excuse for her to leave me alone or because I didn't want to do her work. So I remember vividly the report card came home. Mr. Taylor can do much better. Lazy, needs to take part in the class more. I'm like, lazy. But yeah, growing up, you get this thing that you're lazy. I mean, I know for sure sometimes I'm there, not 100%, so I might be just chilling, trying to just recuperate, you know, and you hear, Sean, you couldn't do this, Sean, you couldn't that, and you know. So the stigma is real. I mean, getting a job, for instance. I mean, this whole thing where they said people with sickle cell, they can't hold a job and they can't work, and that's so not true, especially in my case. I think I work pretty hard. My co-workers might agree, might not, I don't know. But I know for a fact that people with sickle cell usually have a hard time getting employment. I got that firsthand. I mean, I applied for a job. I was shortlisted for the job and everything. And I heard that I didn't get the job because when they reviewed my application, the medical person at the lab, it was a lab that I applied to, had said that I would probably be absent from work a lot. I'd be sick. I would not be a good employee based on the fact that I have sickle cell. And again, I don't know. It's I guess it's people, and you just have to understand that people are people. They see the disease. They don't see you, the person. They don't see what you're capable of. They don't see what you can do. So they basically just stereotype you. Sicklers, oh, sorry, not sicklers, persons with sickle cell. We no longer call people with sickle cell sicklers. It's kind of not kind of taboo. So persons with sickle cell, you're gonna normally have like a low self-esteem. You already have pains, you're suffering from pains and you're not well. So you kind of don't want to really be seen. You don't want to be put on a spotlight kind of thing. So you kind of shy away. I think I don't know how many people had heard because my volume was giving problem, but I said I'd been hospitalized 4 times. The most severe, the one that stands out most of all was when I was living in England. So I went to UTech, back then it was called CAST, College of Arts, Science and Technology. And my final year, which is the same year that I found out I was diagnosed with sickle beta thal, I went on a work and study travel program. I went to England. So my classmates had gone the year before and I was left out. I mean, of course, you know. But this time around, I said I was going. So anyway, I'm in England. I'm first time traveling. First of all, I was scared out of my wits, not just to traveling, but being on a plane. Altitude and the pressurization of a plane is not really something that I was looking forward to. And trust me, nothing is worse than getting sick on a plane. That happened to me as recent as 2019 when I went on vacation. But anyway, I was in England, I'd gotten a job, I was working. I was on my way to work and I got sick. And I just remember coming off the train. First of all, I was running to catch a train. It was winter. Got the train. I wanted to be early. I'm normally on time, but today I wanted to be early. So I took an earlier train, which was about maybe 15 minutes before the one I normally took. Got on the train. I did a bolt. Yeah. Full stretch Usain Bolt to catch a train. Missed the train. Just by a little bit. Just as I reached the door closed. But anyway. So missed the train, but you know, I was on time. Other train came and I got on the train and I sat down and I was okay. And then my legs just felt like they were on fire. I was like, okay, this don't feel too good. So I'm saying, you know what? I'm gonna play it safe. I'm gonna go back home and call in sick. No, my mom always said that always go to work, always turn up, let them see that you're sick, and then let them send you home. Right? So all my life, that is what I've done. I've always been the person to come work. I mean, obviously, if I'm having a 10+ crisis, I'm not going to turn up. But I mean, if the pain is like 5+ 6, I'll go to work. I'll try. But I'm on the train, and this is like, okay, my legs, I feel right, something not right. I've never felt this before, not this level, right? So I am thinking about it. I'm like, okay, let me come off at the next stop, cross the platform, and go back home, take another train in another direction. Came off the train, okay, got over to the platform, boarded the other plane, and then that was it. My legs just gave out. So when I got back to my stop to go home, I couldn't walk. Now, this is England. I mean, back then, I mean, you know, racism. I mean, people saw this black guy limping, then the limp became a crawl, and then that's it. Now, where I lived from the train station was like from about LHEWco to about UTech. So imagine crawling from the train station, hands and knees, because I couldn't stand. So I'm crawling hands and knees from the train station back home, right? Now, we lived in a 3-story apartment in Halston, and by the time I got there, I was tired, I was messed up, I was in agony. So I ring the buzzer, my friend Bobby, big up yourself, David, big up. I rang the bell, he came down, I'm like, Sean, you're not gonna work, what do you? So I'm like, Bobby. Right. So sorry about that. So I said, Bobby, you need to call the ambulance. So call the ambulance, rush me to the hospital. I was there for like 2 weeks. And that was the worst I've ever felt in my entire life. But it just goes to show that, I mean, you can't really make plans with sickle cell. I mean, I'm planning to go to work early, you know, get some stuff done and come back home. It never worked out. And that is what life is with sickle cell. It's challenging for your social life, it's challenging for your school life. As I said, I missed exams. Socially, I missed events with my friends. Work, okay, I can't tell you how many times I've been absent from work. Not as bad as it, I guess, could have been, because like I said, mommy said, turn up and let them send you home. So at least you put out the effort. I mean, if you have a boss that's understanding and is familiar with the condition, then that also helps. If they don't, then you know, so that they mess up about. You try and be as normal as you can. You try to put out 100% even when you only have 10. So there is still a lot of misinformation about sickle cell. People still really don't know what it is. They might see you looking healthy and okay today, and a couple of minutes they might see you and they'll say, oh, you know, I found my farmer, you don't want to work, or probably don't want to participate or whatever, but that is just not true. Sometimes you'll be there. I can't tell how many times I've gone to work and I'm okay. 10, 15 minutes into work, I start feeling lousy. I'm in pain. It's so unpredictable, you can never tell. For me personally, I have triggers that usually cause me to get sick. Cold, I love the cold, but the cold is one of them. Stress, and of course, exertion. You will be putting out 100%, and sometimes in putting out 100%, you overwork yourself, you go too far, you push yourself too far. As a result, you get sick. So I try to limit my exertion in terms of putting out. So you know, you put 100% and you're going to go over the 100 sometimes. When you try to have to kind of pull back sometimes, because I realize that sometimes I've overboarded it, and that's when I get into problems. For me, I don't get enough sleep, and that's one of the things as a person, for everybody in general, but for a person with sickle cell, you need to rest. Rest is how you recuperate from not just your daily work, but as a person with sickle cell, when you get sick, rest is how your body kind of recovers from what it's been through. With sickle cell, remember that the cells, the blood vessels, you don't get oxygen. As a result, your cells, your organs don't really get as much of the nutrients and the oxygen that it should. So you're kind of tired, you kind of, you mash up basically. So it is important that you get rest. I don't really get rest. With my job at LHEWco, I am a medical technologist. I work in blood bank hematology. We don't close. The lab never sleeps. Big up pathology, hematology, blood bank. Yeah. Big up to the crew. So we are always open, and I do what's called night duty, in which you basically you work nights. You ensure that patients are ensure that patients are get whatever tests they need. I work in the blood bank, so for me it's blood. To make sure the patients get the blood for the surgeries. If they're coming through A&E and they need blood or blood support, blood products, then that's me. Now we go 24 hours. So there are times when I'm on from the Friday into the Saturday. So, and then probably come on the Sunday. So it's kind of hectic. So for me, I would say rest is the most important thing that I don't get. That would probably be one of my major triggers. Nutrition as well, hydration. You have to drink a lot with sickle cell. It makes a huge difference. You don't want to get dehydrated because that can send you to the hospital with a sickle crisis. Nutrition, obviously you have to eat right. This is for a normal person. For a person with sickle cell, it's the same thing. You have to eat. You have to make sure you eat properly. Eat on time. Eat 3 squares a day. Well, I only eat 1 or maybe 2. Okay. The older you get, you need less of everything. But yeah, for your sickle cell, a person with sickle cell, you kind of need what you need.
Mr. Taylor,
Yes.
Mr. Taylor, I tell you, the spotlight is on you. The spotlight is on you, and this forum is about people like you and for you. And you have given us a wealth of information, inside knowledge as to what it is like living with the condition. And so what I'm going to ask you to do now is to give us a moment to digest some of this, because I myself am winded just trying to absorb all of what you have just said and try to imagine, what it is like living with the condition. So I'm going to ask you to just hold on for me a second. Let us go to our next presenter, and then we will come back, because I know for sure, I'm seeing the chat, I know for sure there will be a lot of questions coming back for you. So you said you need to be hydrated, so go drink some water and prepare yourself just now for the questions that I'm sure will be coming your way. Thank you very much, Mr. Taylor. I thank you very much for sharing that. Very insightful.
You're welcome.
Doctor, okay, so today is the day when I'm speaking things into being. So Mrs. Dawson Shaw, right? Today is the day we're speaking things into being, right? The platform has been laid. Dr. King has told us what the disease is. Mr. Taylor has told us what it is like living with the disease. And now we could not stop him because it is about him and the disease. And time is upon us. So I'm going to ask you now to share with us how the government assists this program and people living with the disease.
Good afternoon, everybody. Are you seeing my screen?
Yes, we are.
Okay. Thank you so much for inviting the National Health Fund to be a part of your webinar today. Always a pleasure to go out to share the information in relation to what we have to offer to the Jamaican population in their time of need. So we're going to talk a little bit about the fund, just in case anybody is not familiar with what we do, the individual benefits program, and then zoom in on the sickle cell that we cover, as well as how persons can apply to be a part of the program. So the National Health Fund is an agency of the Ministry of Health and Wellness. We were established by the National Health Fund Act in April of 2003. There are a number of core functions that we have. We have the health promotion and public relations. Oops, do forgive me. Management of the pharmacies in public sector, institutional benefits and projects where we help with activities that take place in healthcare facilities, equipment, repairs, procurement, warehousing, and distribution of pharmaceuticals and medical sundries, and the individual benefits program, where we have the NHF card and the Jamaica Drugs for the Elderly program. The NHF card provides benefits through subsidies for 17 chronic illnesses. The Drugs for the Elderly program, we look at 10 chronic illnesses there, and it's for beneficiaries. These are the persons who are enrolled in our program. We refer to them as our beneficiaries. That group is 60 years and older. How does one access a benefit? So we have the individual benefits program. We have the NHF card. This is a cradle to the grave group, and the JADEP, persons over 60. For the over 60 age group, we have a list of pharmaceutical drugs. For the NHF card, we have prescription drugs, diabetic supplies, and respiratory devices. So this list we have with the subsidies attached in-house, and then we have a network of provider pharmacies across the island in excess of 400, where persons all over, in all parishes, there's representation. Persons who have one of the 17, they come, complete the application, submit, they get their beneficiary card. So the beneficiary card goes to the provider pharmacy where the benefit, whichever one it is, can be accessed. So, of course, you need to know what conditions we cover to see if you're eligible for any of the programs. NHF card has 17 here: arthritis, asthma, benign prostatic hyperplasia, breast cancer, diabetes, epilepsy, glaucoma, high cholesterol, hypertension, ischemic heart disease, lupus, major depression, prostate cancer, psychosis, rheumatic fever, sickle cell disease, which was added in June 2015, and vascular disease. The benign prostatic and the prostate cancer, those are for the male population. The JADEP for the over 60, we normally refer to this as a subset of the 17, because if you look, you'll see that some of the conditions are in fact common. So for persons who are enrolled for sickle cell disease on the program, and for all persons enrolled, we pay a subsidy. Our subsidy is fixed. So for particular items, the subsidy will vary. You may find that we have an item where the subsidy is $50. There may be another item where the subsidy is $200. The subsidy varies. What happens is that when that individual goes to the pharmacy, they are going to present their prescription along with their NHF card. In the processing, NHF subsidy will pick up whatever we allow, and then the difference is on the beneficiary. We'll talk a little further on what happens if the person has private health insurance. For the 0 to 18 age group, we know that these individuals are largely dependent. So we did institute what is known as a double subsidy for this cohort. So if we're paying $50, let's use an item loosely for aspirin, then the 0 to 18 years age group, they will get $100 for their aspirin. The day they turn 19, of course, they will now be enjoying $50 like all other adults. Dr. King made mention of this special benefit that we have for the sickle cell unit patients. Persons who are in that group are not strictly defined as users of the public sector. So through discussion and representation in 2021, arrangements were made for persons coming out of the sickle cell unit with their prescriptions to have these filled at drug-served pharmacies at no cost. So just as in the general public sector, if you go to a health center or a hospital and fill your prescription, you show up at the, you get the prescription, you show up at the pharmacy and it is filled at no cost to you. This special arrangement was made for persons who use the sickle cell unit. There's a list of pharmaceuticals that are covered for sickle cell disease, and they are listed here. The ones in blue, further to discussion and requests from Ministry of Health, they were added in 2021. And I'm pleased to say that since we have added these items in 2021, we are seeing where persons are making use of the benefit that has been extended. So for the application process, and this will apply to sickle cell as well as any of the other 16 illnesses that we cover. So persons must be diagnosed with one of the conditions to be eligible for the program. You need to have a TRN number because that's one of the requirements. This is a cradle to the grave program, and it is not true to think that children, babies can't get TRNs. Yes, they can have their TRNs. You go to the tax office with a birth certificate. They will explain the process there. The TRN is issued, and then the individual or the caregiver parent can proceed to do the application for the card. So how does that go? We have an application form which is used to apply for either the NHF card or the drugs for the elderly benefits. The form is also used to update or change your records. So let's say you have changed your name, your address, your telephone number. We ask that you also complete the form so that we can have updated records in case we need to make direct contact with you. We also facilitate card replacement. We know sometimes somebody may inadvertently sit on the card, it's left in the car in the sun, it becomes warped, and we don't want persons to be disenfranchised from the benefit. So form is completed and the card is replaced. The card has 3 sections. Section A is where we have the applicant's information, including the TRN. There's a slot there that outlines very clearly everything that we need, easy to complete. Section B is completed by a guardian for persons who are under 18 years of age, or if the individual is incapacitated or in an institution. Section C is where the physician is going to indicate the condition that the person is to be enrolled for, and the physician will tick the condition or conditions, if there are more than one, sign and give their MCJ number, Medical Council of Jamaica, so we have everything properly documented. The application is then submitted at any of our same-day locations, and within a short time, card is in hand. What we do indicate to persons is, this is what the form looks like, Section A for the applicant, and as you see, it's quite clear where you're to put what. Section B for the guardian, if necessary. So if you're doing your own application, you're over 18, you're not incapacitated, Section A and C are the ones that you would concern yourself with. Once this card is submitted, in short order, the form converts to card. Card is what you take with you to the pharmacy so that the subsidy benefit can be applied to your cost. So where are you going to submit this form? Because we like to tell people that if you leave the doctor's office with the prescription, it could be that Mr. Taylor did indicate that he found out he was a sickler at a particular age. So you're in the doctor's office, you find out that you're living with sickle cell disease or any of the other 16. You don't have to be scratching your head and wondering, how long is all of this going to take for me to be able to access a benefit? You just ask your physician to complete his section of the form right then and there. You proceed to one of our same-day locations, submit your form, receive your card, proceed to the pharmacy, and all within the same day, same half a day even, you are able to get your benefit. Where are these places? We're at the head office, Dominica Drive, their drugstore location at Union Square. All the hospitals, we have same-day services. Cornwall Regional, KPH, St. Anne's Bay, Mandeville Regional, Maypen, Princess Margaret, Black River, Savlamar, Spanish Town, Noel Holmes, Falmouth, Port Maria, Percy Junior, Port Antonio, we're all there. And some of the health centers, Greater Portmore, Santa Cruz, Hagley Park, and Linstead. You may ask, so where are these pharmacies that I can take my prescription and my card to access the benefit? And as you see here, we are in every parish across the island. Most of the provider pharmacies have a sticker on the door so that you know that they are a part of the NHF provider network. But as I indicated, there are in excess of 400 provider pharmacies. In relation to payment, there's a sequence. If you're over 60, and this particular thing that I'm indicating here, we'll talk about it if you are a sick person living with sickle cell or you're not living with sickle cell. So if you are living with sickle cell and you're over 60, the JADIP benefit would not apply. Sickle cell disease is not one of the conditions covered under the Jamaica Drugs for the Elderly program. So this step 1 would not be applicable. Step 2 would be applicable. So the NHF card is going to be swiped and the subsidy benefit, whatever the amount is, as long as the items are covered on the program under sickle cell, that benefit will be enjoyed. If you have private health insurance, that will be swiped next, and then the patient makes some payment out of pocket. Just for your information, if an individual has diabetes, hypertension, asthma, or any of those other conditions that are common to the Drugs for the Elderly program, as well as the NHF card, then the JADIP benefit will go first, then the NHF, private insurance if that is had, and then the patient pays the balance out of pocket. If you need more details, you have any queries at any time, we encourage you. Call us, send us an email, talk to us. If you have challenges, if you have criticisms and complaints, let us know. We want to know everything so that we can continue to improve what we do as we serve you. At our head office, the business hours are Mondays to Thursdays, 7 a.m. to 4:30. So depending on what shift you're on, you can stop by on your way to work. On a Friday, we are here 7 to 3:30. We have a call center that's open 7 to 7, Monday to Friday. So though the office is closed at 4:30, you can still call in and you have your matters addressed. Anything else that you may want to know about the National Health Fund, you can go on our website. Our telephone contact is here. We have guidelines for healthcare professionals, which our pharmacists and our physicians use to assist them in relation to what it is that we cover. We have the individual benefits brochures. There's a brochure for every one of the 17 conditions. So you can actually go to the website and see what items we cover for sickle cell, as well as what the subsidy benefit is. So you have an idea what the expectation is as you head to the pharmacy. Not only do we want to be here for you in relation to providing a subsidy so that you can fill your prescription, we want you to continue through you, your relatives, your neighbors, your friends, to adhere to the medication. We know sometimes it's difficult to remember to take and to keep up every day. So here are some little tips for you. Ask a friend or a family member to remind you to take your medication. Refill your prescriptions on time so that you don't run out. Use one of those little pill boxes where it tells you Monday, Tuesday, Wednesday, Thursday, every day for the week. So you don't have to try and recall, did I take it this morning or whatever? Your little pill box will help you. Set an alarm. Keep a medication calendar and make a note every time you take a dose. We know that we are not a static people, we like to travel. So carry your medication with you when you travel, whether you're traveling locally or overseas. If you're going overseas, contact the NHF so that we can approve a drug advance for you if necessary, so that you are not out of your medication while you are away. And that's it for the National Health Fund, your partner for a healthier you.
Okay, great. Thank you very much, Mrs. Dawson Shaw. Much appreciated with that. And now we are strapped for time, but we want to hear from you. So we are going to go straight into the chat to get some comments and feedback from what is happening here. Wonderful platform has been laid, and so now it's time to hear from you. Mrs. Ruth Rooms, what's happening in the chat?
Okay, so we have a number of questions listed, and I had actually requested one of my colleagues to take that on, but let me go ahead. And the first question was from Miss Michelle Palmer. She was asking, can you explain a little more on hydroxyurea? I think I'm mispronouncing it. Dr. King, could you help us here? But she would like some more information on that drug that seemed to be helping.
Sure, not a problem. I had actually answered in the chat. I had answered a number of the questions in the chat. But hydroxyurea, as I mentioned, it's a drug that was actually used in cancers. But one of the things that they found in using it is that it could increase hemoglobin F. Now, hemoglobin F is another hemoglobin or fetal hemoglobin is the hemoglobin that we produce when we are in utero. So when the babies are in utero, we make hemoglobin F. When you are born, you stop making fetal hemoglobin and you start to make either hemoglobin A or hemoglobin S or hemoglobin C, depending on what your adult hemoglobin is. Now, what studies have shown is that if you basically use a drug to tell your body, make fetal hemoglobin again, okay, that fetal hemoglobin now within the red blood cell interferes or with the sickle hemoglobin being able to change the shape of the red cell and the characteristics of the red cell. So you end up with a red cell that is more likely to stay in the round, soft, flexible shape. And as a result of that, it decreases the complications associated with the disease.
Thank you so kindly.
So I'm seeing there's a question as well. I think this will be for Dr. King, Miss Ruth Rooms, you can just assist in it. So
yes.
Is it possible for persons with the trait to have pain?
Okay, so again, I had answered that in the chat that the sickle cell trait is essentially a benign condition, okay? However, anecdotally, we do know of persons who have the sickle cell trait who have, reported problems such as bone pains, especially under extreme conditions. What we always say is that if you have the sickle cell trait and you are having significant complications, then you would certainly need to visit your healthcare provider. Okay?
Mr. Taylor, I know you spoke about the stigma associated with growing up with this disease. Could you just remind us of what it is like or what it felt like at the workplace? What was the support system like for you?
All right, so okay, so as I said before, I'm a medical technologist, not a technician. What we do is we're the person that do the lab tests. The doctors order some tests for you. We're the persons that do the actual tests. The glucose test, the test for your CBCs to see if you have anemias or whatever else. So at my workplace, I work at LHEWco pathology department, hematology and blood bank. I do what's called night duty, which is a 24-hour shift. Essentially, you basically cover the blood bank for anybody that comes in and needs blood, or if anybody's going to be doing a surgery, the gunshot wounds, the stab wound, whatever comes in during the night up to the following morning. That's what we do. So you don't really get much in terms of rest. You're actually on your feet working the whole night. So it's very challenging, it's tiring, but yeah, that's the job. That's what we do.
Okay, thank you very much, sir. And could you just remind us as well about some of your coping mechanism, because I heard from Dr. King's presentation, and you spoke about it earlier, about the pain crisis. Could you talk to us about your coping mechanism?
Okay, so for me, I think I told you what my triggers are. Stress. So the first one for me is de-stress. So de-stressing for me involves anything from music. I like music. I like watching movies. So listening to music, watching TV, movies. I try to basically have as much quiet time as I can. If I'm home, I try to just become easy and just relax at home. But trust me, music, I can't tell you how much music has helped me. It really takes a lot of the craziness that, I mean, I'll be in pain and I put in my headphones and I'm listening to music, and it just calms me down. It helps me to de-stress, especially at work. So people say, listen to music and say, "Boy, Sean, can I listen to music?" But yeah, it's very therapeutic for me. It helps me to cope with a lot of what I'm going through as a person with sickle cell. Of course, I cannot emphasize enough that you need to take care of yourself. As a person with sickle cell, you know your triggers, you know what makes you sick. You also need to know what keeps you healthy. So hydration, nutrition, rest, support. The support group, as you said, is very important. Family, my wife, my kids, my mother, my siblings, they all play an important part in my coping with a disease that has really been very challenging for me. My work family as well. Yeah. I tell the truth, some of the times, yeah, you're not feeling well, but you still push yourself on the work. Some of the time, just being around them, the jokes, just the camaraderie, sometimes it gets you through the day. Trust me, it goes a long way to getting you through a rough day. Just having your work family around you, the vibe, the support, it really helps.
Just to remind persons that this is being recorded and it will be shared on the library's YouTube channel. So from the YouTube search bar, you can type in LHEWco Mona Library, and you will find all of our activities there. This is Dawson Shaw. Part of what I'm hearing here is that even though it's a rare disease, but it's something that needs, that person needs to be educated about. Is there a campaign, or how do you go about promoting the sickle cell disease, or the role that you play as a government institution in the support against this disease?
Thanks for that. It is forums such as these that we use to get the message out. So we go into schools, we have our brochures, there's our website. Anybody can walk in and ask questions or telephone. any group, any organization that is interested in having the NHF be a part of any meeting that they're having, neighborhood watch, PTA meeting, we will come and share what it is that we do if they will have us. We also reach out to different groups at different times to find out if they're interested in having us come to do presentations. In addition, we look out for particular months of the year. Dr. King mentioned that this is sickle cell awareness, so we tend to zoom in on particular conditions at particular times of the year. But anytime you want to have us, if anybody in this forum wants us to come and speak to any group that they are a member of, aside from this, just make contact and we will see how it can be accommodated.
All right, well, I have your contact information and we will definitely be looking forward for a future partnership with you, the NHF.
Yes.
Dr. King, I'm not sure if you had answered this question in the chat. If you have, sorry. Are there any studies about how the trait affects those who are carrying it?
Right, so there are studies, but very few, okay? And so, persons can always, Google if they're interested, but very few studies really looking on the trait, and it may be worthwhile that is an area that a lot more research needs to be done.
Wonderful. All right, so thank you very much for being here, and this is what the LHEWco is about. Before I continue, let me just ask my colleagues, Ruth, are there any more questions in the chat? Let us take one more question before we wrap up. Is there any more question or comment that you want to share? All right, so there is none. Well, let me use this opportunity to also tell persons thanks. The vote of thanks will be coming up shortly, but I'd still like to say thank you for being here and for taking the time out to be educated about the sickle cell awareness. And the questions that are in the chat that have not been answered, right, they will be asked to the presenters. And when the video is edited, the questions and answer will be placed in the description, so you'll be able to find it there. We did indicate that because of limited time, we may not be able to answer all the questions in this forum, but we will make an effort to pass those questions on to the three presenters, and then we will place it on the description on the YouTube channel when that video is made available. All right, so Mrs. Ruth Yufar, could you please do so kindly to bring to us the vote of thanks?
Thank you very much. And a pleasant afternoon, everyone. Just want to share words of thanks and appreciation to all our three presenters. To our first speaker, Dr. Lesley King, we are grateful for your expert data shared on what sickle cell disease is, SCD, the 4 various types, how we get it, the inheritance patterns, its origin, and so on, and the national course consequences and intervention thereof. We want to thank you for how you have taken your time to inform us comprehensively of the disease ed, the genetics, so on, disease modification, possibility of that, and the importance of routine health care, and that there can be 2 possible cures, BMI and genetic therapy. It is also sad to know that there exist persons who may die, persons like children who may die before they're 5, but nonetheless, our policies, the policies that we have on sickle cell and the grace of God will help us to navigate. And for our second speaker, Mr. Sean Taylor, we appreciate your courage in sharing your experience and all your successes nonetheless. We are grateful that though you were hospitalized for 4 times, you have thrived through it all amidst the pains in your back, your legs, your arms. We know by the grace of God that you are living, every moment, leaving nothing to chance. Do continue to live each day as you are creating your own legacy. God will continue to be with you. And for Mrs. Catherine Dawson Shaw of the National Health Fund, thank you for sharing with us the 5 arms of the National Health Fund, the National Card, Health Fund Card, which is the cradle to the grave card, right? And the JADEB experience for those who are over 60 years. Thank you for the sharing with us the beneficiaries and the benefits, the 17 illnesses that are covered. Thank you very much, because my father also is a beneficiary, even though he's living with diabetes. Thank you for sharing with us the application process. You really took your time in comprehensively sharing with us how we can go about it, and also informing us that even a child, no matter how young they are, they can also acquire a TRN card. Please look forward to us asking some more questions. Thank you all, the 3 presenters that we have today. We are really grateful for your time.
Thank you, Mrs. Rooms-Ufar. And in closing, we're going to ask our 3 presenters if they would like to share 30 seconds, their final comments with us. Who's the brave soul? The spotlight is on Sean and Mr. Taylor. So let us throw you in the waters. Mr. Taylor, 30 seconds. What do you want to leave with us?
Okay, all right. First of all, I'd like to thank Dr. King and the hardworking staff over at Sickle Cell. They have really made a difference in my life. They are my primary health providers, if I can call them that. They are the ones I come to. I keep my appointments regularly. The staff here is hardworking. They are caring. I cannot emphasize this enough. They are caring. The doctors and nurses, my fellow techs in the lab, David, Toshiba, Carl, they all go full out to make sure that you get the treatment that you deserve. I cannot stress enough how knowledgeable and how much of difference the doctors here make. They're really good doctors. They make the disease manageable. Trust me. Dr. King, Dr. Chin, Dr. Simmons, Dr. Alexander, to name a few, the nurses, Nurse June, they are all a very helpful and supportive staff. I'd like to add that for sickle cell, don't hide it. I mean, I was hiding for a long while. I'm now able to talk about it. I'm now able to express myself where it's concerned. People with sickle cell, they are fighters, they're warriors. So you might be down for a day, a week, a month, but you have to get back up. You have to try, you have to get over the thing, you have to get through and try and live as normal a life as you can.
All right, thank you very much. Ms. Dawson Shaw, 30 seconds.
Just want to thank you again for having us and reminding everybody that we're here for you. We know that your health is your responsibility, but the National Health Fund is here to partner with you so that you can live your best life. Thanks again.
Thank you very much. And Dr. King.
My parting words, knowledge is key. So get informed, not only for our patients, to be help in self-care, but as the general public get informed, we too can make so much of a difference in the lives of persons who live with disease. If we understand more, we can empathize more, and we can help, we can be part of their village.
I just wanted to say I've listened to the whole thing. How could I miss it? I'm just amazed at your commitment. You have been there from June when we met, or May, and I really thank you. We are really heartened to see this kind of a turnout and the work you and your team has done, Stretch. Really appreciate it on behalf of the unit as well as on behalf of our patients and other persons and families to really shine and bring focus on sickle cell disease. Much appreciated. And this was really very useful, all three speakers. So thanks.
Let me see, if I get this, if I do not pronounce this name correctly, blame it on old age, right? It's not deliberate, it's old age. I would like to thank Professor Asnani Assad. She was the person that I first came in contact with this initiative to have a webinar on the sickle cell. And we have partnered on a number of other initiatives as well when we had the World Sickle Cell Awareness Day. So thanks much for that partnership. And thank you, our viewers, who stayed the long haul with us. I know that this information, I can see it in the chat, and it's well received, but let us not keep this information to ourselves, right? You saw the brave soul, Mr. Taylor, just want to share with persons what his conditions are like and what it is like living with it, right? So let us share and help us support, give a supporting hand to all persons without discriminating. Right. So thank you again for being here, and you can follow us on our social media platform on YouTube, the Facebook, Instagram. All right. And we will definitely be having more informative sessions like this. Since you're here, let me give you an inside kind of information. We're going to also invite you again to book in your calendar of overcoming imposter syndrome, right? And that is slated for October the 11th, right, at 11. But we will have more information going out on that. So thank you for being here, and thank you so much to the presenters, all of you, wonderful job. And we look forward for having more partnership as we strive to educate all who we can. Thank you very much, and thank you, LHEWco team, for your wonderful support. This could not have happened without your support. Thank you so much. Have a wonderful good afternoon. Thank you again.